We move on to our next talk. Probably this was considered to be a debate, but then it's a talk because of certain reasons. For this, I would like to call upon the chairperson, Dr. Raja Selvarajan, who is the consultant physician, diabetologist at Medicover Hospital and Kaveri Healthcare, Bengaluru. We welcome you on stage, doctor. And Dr. Prashant Ji, who is the consultant physician, diabetologist at Chitradurga Diabetes Center, Chitradurga.
A very good morning. At the outset, I would like to congratulate Disha for putting up such a wonderful scientific vaganza again. And though it was an exciting debate which was expected, nevertheless, we have Dr. Manoj Chawla who will make it more likely, more experience-rich data which you would show in the form of CGM. So we have Dr. Manoj Chawla who doesn't require much of an introduction, at least in our country. So he is here to speak about CGM in type 2 diabetes, when, why, and how. Over to you, Dr. Manoj.
Thank you. Thank you, chairpersons, Manohar and Disha group. Yes, I was looking forward to the debate with my friend Rakesh. Unfortunately, he had a family medical emergency and had to get back to Jaipur, which is then Dr. Manohar then asked me to speak on my other passion, which is CGM. So over the next 15 minutes, let me speak on CGM in type 2 diabetes. When, how, and why. And I'm going to change that order of when, how, and why to throw some more perspective. A quick show of hands. How many of you here use CGMs? Oh, that's a good lot, so wonderful. And the reason I would always start is that you cannot improve what you cannot see, and hence the need for looking at the larger picture. Why CGM? Though HbA1c continues to be the gold standard for measuring glucose control, well, it tells us just part of the story. Even when we're looking at an SMBG, we understand today that finger pricks, which continue to be the predominant means of monitoring, would still have its limitations and may miss the large picture as shown in this cartoon here, that you may miss the highs and lows. Even for those who test more frequently, you may still miss a lot of highs and lows, and hence it's only the CGM which can show you the complete profile, patterns, and trends. Let me also remind everyone that CGM is a technology that measures, as I said, the glucose pattern, the trends, and the direction. You cannot hold it against the CGM that there may be a difference between the CGM value and a blood glucose value or an SMBG value, because CGM measures interstitial fluid glucose, and there is a lag period, and there is a difference between interstitial fluid glucose and blood glucose. The limitations of A1C are known to many. It will never tell us about a hypoglycemic episode. It will not be the most accurate in terms of anemias, hemoglobinopathies, and so on. And of course, the drug interferences with common substances like vitamin C, etc., you may have A1C going haywire. Different time in range and different clinical decisions. So one of the metrics which has emerged through CGM use that we look at now is the time in range metrics. Essentially, how much time is your patient spending between 70 to 180? The standard recommendation is 70% and above, and I'll show that. But when we talk about TR, you predominantly refer to 70 to 180, except in certain special situations. So this is one of the reasons that you can have patients with same HbA1c but completely different profile. To the left, you see a profile of an individual with an A1c of 7.2, 46% time in range, 18% time below range. On the right, you're looking at an A1c of 7.2 with 64% spent in range with only 1% below range. Which profile would you prefer for your patients? How many of you would prefer the profile on the left side of the chart for your patient? Any of you? How many of you would prefer the right-sided graph? So most clearly have the idea, right? The second important aspect through CGM would be picking up hypoglycemia at different levels of A1C. Again, a quick question. How many of you suspect hypoglycemia in patients who may have an HbA1c of 9.5 or 10 and above? So I see a few hands go up, and clearly today we understand that a high A1C does not always mean high sugar. It can very often mean high variability, and that lows and highs, including a lot of hypoglycemia, may actually lead to a much higher HbA1c. So here is a patient whose A1C or estimated A1C is on the lower side. You're picking up 27% hypoglycemia, not shocking. Somebody may come to you on drugs which can cause hypoglycemia, has an A1C of 5.2, 5.3, you will want to rule out hypoglycemia. But then here you have an individual whose estimated A1C is 10.2, the actual A1C could have been 9.5 or 10.5, either. But what you see in such a patient profile is again the huge variability. You're seeing the hyperglycemia spikes all over the place. You can see this all over, and then of course you're seeing the drops happening in the nocturnal period. So 10% hypoglycemia with a time in range which is only 21%, so hugely variable individual. Then you also have instances in your clinics where you'll have patients coming to you with high SMBG readings or high lab values where the HbA1c is normal. And it's not once, it's not twice, it's a regular pattern that the sugars are in the 200s, 250s, but the A1c is 6.7, 7.2. There is something amiss. What do you do there? It's probably CGM, which is going to tell you the right picture. So you have these similar patterns with normal or high sugar readings and normal A1C. And sometimes you'll have exactly the opposite, that the SMBG that they are showing you or the lab readings that they are showing you are seemingly in a decent range, 120s, 150s, 160s, but the HbA1c is 12%. Again, a huge mismatch. So what is going wrong? What to rely on? How do you see the whole picture? You'll again go back to doing a CGM for such an individual. We then move to understanding how, right? There are multiple CGMs available in India. At our center, we use all of them that you see here. And then some new ones coming. Dexcom should be with us by end of the year. The other strength, of course, is don't try to make assumptions based on what the patient feels or how the patient presents. You can have completely different individuals, somebody who's very, very happy, but has a completely different profile. And it's not just that opinion counts, but you need to see the full picture. So how to interpret these CGM data? So you have a 3-step structured analysis. You're going to look at the time in range bar, what you see here. What you see in the green is the target range, as I said, predominantly 70 to 180. What you see in yellow is the above range, and what you see in red is below. Second, what you are able to see is your ambulatory glucose profile, which is actually a software compression of the readings done across a period of time. It requires minimum 5 days for an AGP to form, but you can have an AGP for a 14-day period, a 30-day period, even a 90-day period. So AGP does not necessarily mean only a 14-day period. It can just compress the data over a certain specific period of time. In the AGP, what you want your AGP profile is to be FNIR. You want the profile to be flatter. You want it to be narrower and not really broad. That tells you it's not too variable. And you want it to be in range of 70 to 180. So FNIR, flat, normal, and in range. And then the third aspect is looking at the individual daily profiles. So in the first one, you're looking at, is there a glucose problem? How much is the time in range? How much is the coefficient of what is the glycemic variability that you can see with your percentage CV? You're also seeing the sensor use, extremely important to see before reaching any conclusion that there's at least an 80% of sensor wear and usage. Where you do the CGM and you're seeing sensor use coming as 60%, that is not good enough data. What is the problem and what part of the day is the problem is what you see in the AGP profile, and then how it should be explained or addressed, you move to the daily excursions. So this is a rapid approach to understanding the AGP report. On the right, there are certain aspects for one to remember. Validating the data first, do not be misled just by the TIR and look at the whole picture. On the left, let me move ahead by saying, if the TIR target is met, which is 70% in range and above, and the time below range less than 4%, then there is no specific reason to undertake any major management changes. But then go and look at the AGP and discuss any specific issues if the patient is having. These are the CGM targets, which I said earlier, which one should know these numbers, just the way we know that the A1C should be less than 7 or 6.5. You should know these numbers for your time in range across majority of the population. For pregnancy, there's a different range, which is there. And today, for people with pre-diabetes or looking at reversal of the process, you're looking at time in time range, which is 70 to 140. So going back to understanding the graph, as we said, If the time in target is met, not much to do. What if it is not met? Then you go to the AGP, the big picture first impression then structured by time of the day. You develop hypothesis. There would be three things possible. You have predominant hypoglycemia risk if your TIR is more than 50%, but your time below range is more than 10%. So time below range is more than 10% and TIR is more than 50%. You have a predominant hypoglycemia risk. If the TIR is less than 50 and the time below range is less than 5, then it's predominantly hyperglycemia. And then the third is the worst of the cases, which we see very often, that your TIR is less than 50% when the time below range is more than 10%. Exactly the graph that I showed you earlier of that huge variable individual with an estimated A1C of 10.2, which is a predominant variability risk, giving you high sugars at the same time, frequent occurrences of hypoglycemia. And finally, beyond that, look at the IDP, which is individual daily profile. So many of us in our busy practice just glance at the TIR metrics and say it's fine. So look at those TIR metrics bar, look at the sensor use, look at the glycemic variability, move to looking at the AGP to understand whether there is day-to-day variability and what is the intraday movement of the sugars and which part of the day is the problem zone, and then get into the daily profiles to see what's going wrong on different days. It's possible 5 days of the week are fine, over the weekends things are going haywire. Finally, moving to the third part, which is when, and I would state every stage of diabetes. And today the recommendations also strongly support this. This is the ADA 2026 standards of care, which talks about use of CGM in not only insulin-treated patients, but not only on anybody with hypoglycemic drugs, but for any individual where monitoring just cannot be wrong. It is a huge impact of CGM in today in lifestyle modification and supporting your decisions. This is the RSSDI expert consensus on monitoring, where again we've very Indianized our recommendations. The recommended frequency in type 2, we have said, is twice per year for patients whose TIR is more than 90% and TBR is less than 1. So twice per year for such individuals is fine. Once in 3 months or 2 months for those whose time in range is more than 70% with a TBR which is more than 4, or time in range is more than 50 and the TBR is more than 5. So they require a little more frequent monitoring. Use of clinical judgment and individualization will always be the case, and treating physicians can take individualized decisions. Of course, cost continues to be a factor. And then again, from the RSSDI clinical practice recommendations, where all we should use, we've enumerated those cases, especially hypoglycemia awareness and other. This, of course, is getting updated, and in Bangalore here, when we do the annual meeting, we'll have the new RSSDI clinical practice recommendations 2026 being released and updated on all fronts. So let me show some clinical scenarios where we use it, and as I said, everywhere. So somebody with pre-diabetes, 52-year-old female, corporate worker, doesn't have the time, A1C 5.8, has gained weight. Many such people are coming to our clinics today. How many of you would want to start a drug for her at 5.8? Right? If she's coming to you especially for weight management, maybe you may consider. But metformin, by the way, is approved in India for use in pre-diabetes. How many of you want to use metformin for her? So at 5.8, most of us would say, no, have a better lifestyle, try and lose weight, get things in order. But what is things in order? Is it the same standard diet advice given to everyone? If I do a CGM, will it going to help me understand what my pattern is? Where am I going wrong? Is rice and idli bad for everyone, or is it some other food aspect at some time of the day? So CGM is a wonderful tool there. This was, and again, as I said, in pre-diabetes, please change the setting to 70 to 140. Look at time in tight range. Time in range will give you a false sense of satisfaction. So on the left side, you can see that when we did it first, her time in tight range was about 83%, not bad. But you're clearly identifying the spikes there, which is written in the median in the red on the left side. She understands where things are going wrong. Maybe it's double breakfast, it's the nature of the breakfast, and so on. She makes changes. By July 2025, her A1C has dropped from 5.8 to 5.1, and you can appreciate her time in tight range also going up to 96%. So she's done well. Just like any therapy would have worked, CGM has helped her achieve this. Similarly, in another case of pre-diabetes, again, it's the CGM which is helping see individual aspects. This is an individual who's written down everything in the app, different food items recorded. One other quick word of caution, level 1 TBR, especially between 60 to 70 is not hypoglycemia, especially if you are not on hypoglycemic drugs. In a lot of pre-diabetes individuals, in a lot of cases where you're going to be using tirzepatide, semaglutide, you will see sugars at 65, 64. That is not hypoglycemia. Pre-warn your patients so that they don't panic. Again, another case, which is undergoing IVF treatment, past history of GDM and type 2 diabetes, an excellent tool today to guide anybody who's planning pregnancy or pregnant today. The important thing to remember, again, as you can see in the setting, changed to 63 to 140. So the target for pregnancy is 63 to 140. This will help you guide the treatment changes. Again, through connected care, the pregnant lady cannot always be coming to your clinic. With the CGM, it remains connected. Even though on a basal bolus therapy, that fine-tuning of dosage can be done by you or your associates at the center. Somebody on MDI, 68-year-old male, 38 years of diabetes, on MDI, 3 times regular human insulin, glargine, on OHS, comes to us for the first time. How to make changes? Right? Patient is on sulfonylurea as well as insulin. Do we remove it? One of the best aspects here is again going to be looking at the CGM, identifying the lows where things are going wrong, and then fine-tuning the dosage, which will put the patient back into the driver's seat and have more confidence. Finally, newer therapies coming in. This patient presented with a 12.6% A1C, funnily with glimepiride metformin and repaglinide metformin. Came to us for the first time, desire to lose weight, 12.6%. Said, fine, let's start on semaglutide. We started on semaglutide, changed to another sulfonylurea metformin, gave EMPA metformin and CGM. So besides the change in therapy and addition of semaglutide, the CGM was a huge motivator for such a patient. This is data from another CGM, the links aspect. You can appreciate as we started off, the time in range in the green portion was just about 29.7%. Again, patient being driven because they could see their profile, and of course the drugs that changed helped the patient from there to improve the time in range to 71%. So these are multiple aspects. Also in steroid-induced cases, I need not say steroid-induced hyperglycemic excursions for whatever reason, take help of CGM. There is huge expanding evidence, and I'm not reading it out now, but for every aspect, not only patients with type 1 or those on insulin, but many studies for people with type 2 diabetes not on insulin. Today there is strong evidence. Also in the elderly, across the globe, the evidence has come for use of CGM. This has been a paper from the group that in India, we understand people may not use it continuously, so the intermittent use is what we can strategize. SMBG is not dead. It will be intermittent use of CGM along with SMBG, which becomes the best tool to economize where affordability is an issue. Finally, there are questions raised that the data comes from the West. Is this validated in India? And this was a recent study last year which got published, done by a group, Purvi led this study, in type 2 patient, where we could conclude that the significant relationships between CGM-derived metrics and clinical parameters in Indian patients and their effectiveness was identified, validating that your CGM and TIR metrics are as strongly associated with the control in India like in other patients. So finally, let me leave you with a thought. If CGM can answer a clinical question, improve a therapeutic decision, empower patients to change behavior and personalize diabetes management, then why not think of CGM in every patient in front of you? With that, let me invite you to send your cases. We do run the RSSDI CGM clinical case scenario every month. If you have any interesting case of CGM, please send it to us, rssdicgmclinics@gmail.com, and we'll be happy to include you in the national program every month. With that, Manor and Team Disha, thank you for having me here.
Thank you, Dr. Manoj. We could see the passion of CGM in your talk. It was excellent, and we could see what we missed in the tirzepatide and semaglutide bouncing up here. Thank you. Sure. We all agree that we are moving towards precision diabetes care, and CGM should be a part of our regular management with type 2 diabetes. Not only to look at the flow of the journey of the patient, catching up all the variables and treating them holistically. Thank you, Dr. Manoj.
Thank you.
A wonderful talk.
Thank you.
Thank you.
Thank you so much, doctors. I would request the chairpersons and the speaker to move towards the selfie booth area for the group photo as well as the memento.